So my talk is fast. Uveitis as insight into pathogenesis and pathology. I've never seen such a huge gathering in any uveitis instruction course. Let me start without much delay. Uveitis can be infectious, non-infectious. Non-infectious can be broadly categorized into the autoimmune, and there is a gray zone which can be divided into the autoimmune and idiopathic. Pathogenesis of the uveitis I am not discussed in details. What is the major advancement is the role of microbiome and autoimmune uveitis, particularly in Vogt-Koenige-Harders disease. There is a very good work from the Chinese group of the people. And HLA-B27 positive anterior uveitis with gut microbiome. Let me show you a few cases and describe the pathology of uveitis. This is a 16-year-old boy, recurrent attack of pain, redness and blurring of vision, had history of recurrent fever with systemic hypertension. Renal biopsy showed acute interstitial nephritis. Urinary beta-2 macroglobulin was elevated. And here you can see that acute interstitial nephritis. This patient had non-granulomatous anterior uveitis in both eyes, resolved with topical steroids, and he required oral mycophenolate and prednisolone. With this, there is a complete resolution of inflammation. So we collaborated with the pediatric nephrologist and jointly managed this patient. We published this case in the Indian Journal of Ophthalmology, tubulointerstitial nephritis and uveitis, the first report from the ophthalmologic perspectives in India. This is a 32-year-old lady with blurring of vision, and in the fundus showed multiple corneal spots with retinal vasculitis with hemorrhages. What was the differential? One of the differential diagnoses was systemic lupus erythematosus, and it was proved right when we did the anti-double-stranded DNA antibody, which was positive. Now coming to the infectious uveitis, TB, toxoplasma, and the viral is one of the three common causes of infectious uveitis. I will show some histopathological evidence of intraocular tuberculosis. This is a 42-year-old woman, dimness of vision in the right eye for 15 days. She developed exudative mass near the macula, had raised serum ACE and positive COIM test. That time COIM test was done, used to be done. Treated with high dose of oral steroid elsewhere, developed multiple subretinal abscess, and you can see that diffuse subretinal abscess with retinal hemorrhages. The eye could not be salvaged and went to the panophthalmitis. Ultimately, evisceration was required, but evisceration showed eviscerated tissue showed histopathology. Very interesting finding with multiple myriads of acid-fast bacilli in the subretinal space, showing the direct invasion of the Mycobacterium tuberculosis causing the subretinal abscess. Usually, the tubercular uveitis is paucibacillary in nature. This is one of the rare cases where you could see that multiple acid-fast bacilli. This is a photograph taken from Professor Narsingh Rao, and this patient was initially diagnosed as cytomegalovirus retinitis, but not responding with anti-CMV therapy, including ganciclovir. At this stage, the patient was subjected to retinochoroidal biopsy. Retinochoroidal biopsy showed necrotic retina with the Toxoplasma gondii cyst. There is a few inflammatory cells were seen in the choroid. It's not moving. It's not moving. Yeah. This is a case of an autopsy eye of a CMB retinitis which presented with the necrotizing retinitis with hemorrhage, and histopathologic study of the retinal tissue showed full thickness retinal necrosis with inflammation. And this showed, histopathology showed cytomegalovirus inclusion bodies, which you call Owl's eye inclusion bodies. We did the Eels disease several histopathological study, histopathological, immunohistochemical and molecular biologic study of enucleated specimen of a case of Eels disease. And this is the other eye showing retinal vasculitis with the gross capillary non-perfusion. An enucleated eye, blind eye on histopathology showed multiple vascular channels in the retina were surrounded by lymphocytic infiltration. And this lymphocyte was found to be CD8 positive T cells, T suppressor cells were seen. And with few absent B cells and few macrophages CD68 positive cells. PCR for Mycobacterium tuberculosis, MPB64 and IS6110 both was positive, as well as the real-time PCR was positive. We also studied the histopathology and molecular biologic study of an eyeball of a case of acute retinal necrosis, which is a very rare, and we could see the retinal vasculitis with vascular occlusion, and in fact we could demonstrate the cells with inclusion bodies. In autoimmune uveitis, sympathetic ophthalmia, Vogt-Koenigsegg-Harder disease, intermediate uveitis is three important cause of autoimmune uveitis. We have got the chance of looking histopathology and immunohistochemistry of the same. And here is a gross eyeball section, gross section of the cut section of the eyeball showed diffuse thickening of the choroid. And there is a diffuse inflammatory cellular infiltration, predominantly lymphocytes, involving the choroid with the choriocapillary sparing. We also could demonstrate that Dallen-Fuchs nodule, focal collection of lymphocytes and epithelial cells underneath the RPE, as well as the diffuse infiltration of the lymphocytes in the choroid. Immunohistochemistry showed predominantly CD3 positive T cells. In case of Vogt-Koenigsegg-Harder disease, we rarely enucleated the eye, but one of the eye, which was a blind eye, thicical, was removed, and we did the clinical pathological and immunohistochemical study with Dr. Dipankar Das, and here we could demonstrate inflammatory cellular infiltration in the choroid and diffuse inflammatory cellular infiltration comprising mainly of the lymphocytes. And these lymphocytes are predominantly CD3 positive T lymphocytes. However, there is a few B lymphocytes were seen, but in contrast to the T cells, mostly it is a T cell mediated disease. We have got a very rare case of pars planitis where we did the histopathologic study, and here you could see the pars plana, thickening of the pars plana region. And there is a fibroglia tissue proliferation arising from the pars plana region. And this was a GFFE positive glial fibrillary acidic protein positive, and the trichrome staining also showed positivity. Immunohistochemistry showed CD3 positive T cells as well as the CD8 positive T cells. There is a T suppressor cells, CD2 positive B cells, and CD68 positive histiocytes, and HLA-DR positive cells, indicating that both the T cells and B cells as well as the macrophages take part in the pathogenesis of pars planitis. We did the cytopathology and polymerase chain reaction of vitreous fluid in tubercular intermediate uveitis. This is a rare case of tubercular intermediate uveitis with dense vitritis in one eye. The vitreous vitrectomy is done, and therapeutic vitrectomy was done, and diagnostic and therapeutic vitrectomy showed a large amount of lymphocytes along with the epithelioid cells forming granuloma in the vitreous cavity. So what we showed as a snowball was turned out to be granuloma in the vitreous cavity. PCR was positive for Mycobacterium tuberculosis DNA, both MPB64 and IC5. Lastly, the masquerade syndrome is a primary vitreoretinal lymphoma, and they have got a multiple choroidal infiltrate with leopard skin-like appearance. And patient husband had pulmonary TB, had joint pain with fever. It was thought to be tubercular chorioretinitis. AC-TAP for PCR for MTB was done, was negative. You are suspected for the primary intraocular lymphoma. On the left side, vitreous biopsy was done. MYD88 mutation was negative. FNAV done, which showed clinched the diagnosis by showing atypical lymphoid cells. CD20, the B cell marker, was positive. Patient was given intravitreal injection rituximab and showed brilliant response. And here is the vitreous biopsy specimen, showed necrotic background and with a large lymphoma cells. And cell block preparation showed multiple pleomorphic lymphoma cells in necrotic background. Immunohistochemistry was done, which was positive for CD20. And lastly, I showed a case, showing a case, a 50-year-old man, left eye counting finger 1.5 feet, no systemic amyloidosis. Diagnostic vitrectomy and therapeutic vitrectomy was done, and it showed vitreous specimen Congo red stain positive, showing vitreous amyloidosis. So pathogenesis of uveitis is varied and complex. We still need to learn the nuances of the pathogenesis. Clinico-pathological immunohistochemistry and molecular biologic study to some extent can give insight in better understanding of pathogenesis of in non-infectious autoimmune uveitis. Thank you very much. We'll go to the next talk. Next talk is, I would invite Dr. Kalpana Babu from Prabha Eye Clinic, Bangalore. The talk is Sarcoid uveitis, is it underdiagnosed in our country? Dr. Kalpana, please.
At the outset, I would like to thank Dr. JB for this invitation. And so my talk will be on sarcoid uveitis. Can I have my slides, please? Pointer chahiye. So when we talk about sarcoidosis, it's actually a multisystemic disease, and it's a granulomatous disease which is caused by an exaggerated cellular immune response to either self or non-self antigens in a genetically predisposed individual. And the way we make the diagnosis is by typical clinical features, positive chest radiology and a positive biopsy. But an important caveat is we need to exclude infections such as Mycobacterium as well as fungus. Now this disease has caused a lot of interest because of its similarities with tuberculosis, and it is very similar clinically, radiologically as well as histopathologically. And we do not know the cause of sarcoid, that it's multifactorial. Some say it's environmental stimuli, some say it's infections, especially mycobacteria, atypical mycobacteria, and P. acne. Certain drugs also cause sarcoid-like reactions, and neoplasms such as lymphoma are associated with sarcoidosis as well. So is this disease common in India, which is a high TB endemic country? So when we look at the earlier literature, this disease was actually a disease of the developed world. However, recent reports show increasing reports from India, which is a high TB endemic country. And this is probably because of increased awareness, availability of newer diagnostic technologies such as the high resolution CT and the EBUS TBNA. And also, we are also using newer therapeutic agents like the biologics for cancers, which can cause sarcoid-like reactions. So now this disease is routinely considered in the differential diagnosis of both respiratory as well as non-respiratory diseases, which includes ocular problems as well. So the game is definitely changing in sarcoid, and more so for us because we have started to associate this disease more often with mycobacteria, as with these articles. So how does sarcoid present? In addition to non-granulomatous and granulomatous uveitis, you see this very characteristic dry eye. They all have sicca symptoms, And we've also had a case of hypopyon, which was the initial manifestation of systemic sarcoid, and very rare manifestations such as scleral nodules and conjunctival granulomas in the anterior segment. And posteriorly, they can present as vitritis, they can present as retinal vasculitis. This is typically what we call as the candle wax dripping. Choroidal granulomas, which can be unifocal or multifocal, and depigmented chorioretinal scars, which resemble Dalen-Fuchs nodules-like appearance. Optic nerve and head involvement in the form of disc edema or granuloma. And you can also see pre-retinal and retinal granulomas, as in this case. Sometimes the inflammation will be very low grade, and it is associated with inflammatory choroidal neovascular membranes, like in this case. And you can also have orbital involvement. The lacrimal glands can be involved, orbital tissues can be involved, like in these cases. So generally, when we see ocular sarcoid and a posterior segment inflammation, we usually do a fluorescein angiogram and an ICGA to look for choroidal granuloma. So this case was a partially treated sarcoid. Clinically, though they appear few granulomas, on the ICG there are a lot more. And you can also pick up retinal vascular leakages as well as retinal vasculitis on fluorescein angiogram. OCT is a very useful technology to look at these granulomas, and generally these are well demarcated and they are associated with increased transmission signals. And OCT can also be used to monitor these granulomas. They are slow to respond to therapy, and you can use this to serially look at the AP diameters to see if they are responding to treatment. OCTA is also a useful technology because it can pick up subclinical granulomas which are not visible clinically. Here there is a clinically visible granuloma. You see a hypoperfusion area, and OCT a well demarcated granuloma. Now this area appears okay clinically, but on the OCTA you have hypo areas, and if you look at the OCT, that area has increased transmission signals. So definitely imaging has made a big difference in looking at our cases with sarcoid. 90% of these cases, when you look at them, they have lung or lymphadenopathy, and this can occur at any point of time. In addition, you can have a skin involvement or a history of Bell's palsy, like in this case. You can have glandular enlargements, like in this case, which had a parotid gland enlargement, and it can actually involve almost any organ: joints, nervous system, cardiac, renal, and even the liver. So generally, when we see a patient with sarcoid, suspected sarcoid, these are the investigations which we do: the MANTU and the quantiferon TB gold. Radiology, preferably we look at the high resolution CTs. And these cases usually have lymphopenia, especially if they are detected very early. You can have a drop in the lymphocyte counts. And sometimes renal sarcoids are associated with increased serum calcium. Liver sarcoids are associated with increased liver enzymes, and of course many of them are picked up asymptomatically on PET CTs as well. Ideally, it is always better to biopsy whichever tissue it is available for a definitive diagnosis, and this can be either from the skin or the orbit or from the lung in the form of EBUS TBNA. As we cannot follow these patients with serial HRCTs, generally we do a baseline pulmonary function and follow them up every 6 months. Now, many times the systems are absolutely normal and it is only the eye which gets involved. And this is the revised IVOS criteria, where they have looked at clinical features as well as investigations and laid out certain criteria for ocular sarcoid. But the caveat is you need to rule out other causes of granulomatous uveitis, and this is a big challenge in our part of the world. So we looked at a multicenter study, and this was published recently, where we looked at diagnostic markers between ocular sarcoid and ocular TB in our patient population. And we found that if these cases had a dry eye, retinal vasculitis, especially of the candle wax type, and chest radiology showing hilar lymphadenopathy and fissural nodules, then probably you're dealing with ocular sarcoid rather than ocular tuberculosis. Also, this is a paper by Dr. Agarwal and group, where they have laid out certain diagnostic characteristics between sarcoid granulomas and tubercular granulomas. But there is always a challenge, in our part of the world, because there is a gray zone, and we've had patients who've had both TB as well as sarcoid in the same individual, and we've also had patients who had TB and later on developed sarcoid, and vice versa as well. Prior sarcoid and who developed TB later on. And these are very challenging. So I'll just share a few cases with you. This is my first case. A young male with a history of Bell's palsy, and if you see his eye, he had keratoconjunctivitis sicca. And he had this candle wax dripping type of retinal vasculitis. However, the HRCT showed heterogeneous enhancement, which was biopsied, and biopsy showed caseation necrosis. So though ocular features were so suggestive of sarcoid, the pulmonologist was not convinced, so he gave him a course of ATT along with steroids, but he continued to develop reactivations, and eventually he required methotrexate. And it's been 11 years now I've been seeing him, and he's in remission. Similarly, this is my second case, a 42-year-old lady. Again, there's a lot of contact history. She has constitutional symptoms. Her mother and uncle who live with her had TB. So there was an exposure to tuberculosis. And HRCT did show mediastinal and hilar lymphadenopathy. Now, this was biopsied. Everything else was negative except the PCR for MTB had come positive. So this patient was started on ATT by the pulmonologist along with the oral steroids, but continued to develop granulomatous uveitis, which became pan-uveitis with time. But over a course of time, she developed parotid gland enlargement, which was biopsied, and this turned out to be a sarcoid, non-caseating granulomatous inflammation. And she was put on immunomodulation, and she's been doing well since. This is a third case. It's an intern with granulomat, initially presented as an intermediate uveitis-like picture, and was treated with anti-TB medications for a positive MAN2, but HRCT and QFT were negative. But with time, he started developing a granulomatous pan-uveitis picture, and there was a mild disc edema which started developing. So he underwent a CSF tap, which was negative for mycobacteria, and there was an MRI enhancement on the optic nerve. So the neurologist also felt it could be sarcoid, and this patient was treated with methotrexate and did extremely well. This is my last case, and this definitely was a challenge to me. This is a 62-year-old lady with diabetes and hypertension on ACE inhibitors. So actually this patient had a cataract surgery done elsewhere and was on topical interferon because they diagnosed it as Irwin-Gass syndrome for the left eye. But just a week before coming to me, she had developed her redness and pain in her right eye, and her ophthalmologist had started her on topical steroids. So if you look carefully, right eye has a medium-sized keratic precipitate with synechiae and cystoid macular edema as well in both eyes. So an FFA showed leakage with CME, and the cystoid macular edema was confirmed on the OCT. So we looked at also our probable working diagnosis was either a TB or a sarcoid, and we went ahead and did all the investigations. And what was surprising was the lymphocytes count was down. She had lymphopenia. Serum ACE was on the higher side of normal, but she was on ACE inhibitors. MAN2 and quantiferon was negative, and TBNA showed non-necrotizing granulomatous inflammation, which was AFB negative as well as gene expert and PCR negative for mycobacteria. So everything fitted into sarcoid, and she was started on oral steroids. And what was interesting is 3 weeks down the line, I was told that her culture had come positive for Mycobacterium fortuitum. So the whole thing changed. The whole presentation looked like a sarcoid-like reaction, and the culture came out as atypical mycobacteria, and she had to be treated with amikacin and linezolomide as well as moxifloxacin. So I'm coming back to this article, which is a very interesting article, where it says that mycobacteria might be members, so there could be slow growing types with low pathogenic potential, and they can elicit a type 4 kind of immune response, which we generally see with sarcoid. And interestingly, in this meta-analysis, 30% of the cases had an overall positivity of mycobacterial DNA in sarcoid samples. So thus, what I would say is sarcoid is definitely increasing in our part of the world, but its association with mycobacteria, both typical and atypical, poses diagnostic challenge in ours, and there is always a gray area which is very difficult and poses a diagnostic challenge for all of us when we treat. So what I can say is these cases definitely, if you are suspecting an infection, it's better to treat it with the antimicrobial therapy and watch them for long periods of time. I thank you all for patient hearing.
Thank you, Dr. Kalpana, to bringing out the challenges of sarcoid uveitis. Indeed, like tuberculosis, sarcoidosis can also have protein manifestations and pose a diagnostic challenge, particularly in our country. It's such a close mix-up between the sarcoid and tuberculosis. It's often difficult to differentiate between the two. There are certain markers, like one of the work has been done by Dr. Anuruddha Agarwal, who has showed that the choroidal granuloma is much more in number than in sarcoidosis than tuberculosis choroidal nodules. Also, the OCT features are some characteristic findings. But still, we have got a lot to learn to distinguish between the sarcoid and tubercular uveitis. So, with this, I will come back to Dr. Rima Bansal, who is the professor in ophthalmology in PGI Chandigarh. She would be talking on proteomics in uveitis. It's a very new area. She has done an extensive work, research work on proteomics in uveitis.
Thank you, sir, for this opportunity to speak on proteomics in uveitis. So, proteomics, it's a high throughput technology and a very powerful screening tool for biomarkers in various diseases. And this term was coined by Wilkins in 1996. So, the proteome comes from the word entire protein complement expressed by a genome. So, it's a combination of protein and genome. And it includes large-scale analysis of proteins in a cell, tissue, or whole organism, and it identifies proteins by mass spectrometry. Just in brief, the proteins undergo digestion, and we get peptides after the digestion of the proteins. When these peptides are ionized in mass spectrometry, they break into fragments, they get isolated, they get ionized, and then they get picked up and undergo mass analysis for their identification. So, diseases of the retina or uvea, they cause disruption of the blood-retinal barrier, and this generates changes in the biochemical or protein composition of the ocular fluids and tissues, and this provides the very basis for identification of protein biomarkers in these diseases. So these proteins determine the state of a cell, and we have a huge catalog of proteins in the normal human vitreous. So coming to the use of proteomics in uveitis, we have various ocular samples in the form of vitreous, aqueous, tears, and cornea, lens, and so on. So by and large, vitreous, aqueous, and tears have been the repositories for doing the proteomics works in uveitis. A lot has been done in the animal models regarding proteomics in uveitis, and after this extensive work, now we have publications coming up from in various autoimmune diseases in proteomics. So coming to them, one of the major autoimmune disease where not really a lot of proteomics, but significant amount of proteomics work has been done is Behçet's disease. And this is one work where serum samples were collected from Behçet's disease patients, VKH patients, and healthy controls. And using the proteomic fingerprint technology, a diagnostic model was constructed to differentiate the Behçet's disease patients from the non-Behçet's disease patients. Another study on Behçet's disease where 20 candidate autoantigens were significantly found to be associated with Behçet's disease, and the controls included the other diseases like Takayasu arthritis, Sjogren's syndrome, ANCA-associated vasculitis, and healthy controls. The protein CTDP1 was validated as a Behçet's disease specific autoantigen, and this anti-CTDP1 antibody was found to be serving as a novel autoantibody for detection of Behçet's disease. Another work on the Behçet's disease where they've used the tear proteomics, and what they've done is a substantial number of proteins have been detected in the tears of these patients with Behçet's disease, and they compared the tears of the eyes which came with a relapse versus the tears of the eyes which remained quiescent, and they found that there was a significant potential of these tears in Behçet's disease to serve as a biomarker for the disease activity in Behçet's disease. GIA-associated uveitis, another autoimmune disease where proteomics is evolving. This study highlighted the role of aqueous humor in diagnosing protein biomarkers in GIA-associated uveitis, and they found that transthyretin, that is TTR, differed significantly in GIA patients as compared to the other groups, and this was found to be a potential biomarker for GIA-associated uveitis. The serum from 3 groups of patients, including GIA uveitis, GIA non-uveitis, and healthy controls, was incubated with the porcine iris, ciliary body, and retina tissues, and the relative binding of the sera with the iris tissue was significantly higher in GIA uveitis eyes as compared to the non-uveitis eyes or controls. And since iris is the major site of inflammation in GIA uveitis, this study further gave evidence that autoantibodies may be involved in GIA immunopathology. Tears again were used in GIA-associated uveitis, and they contain similar cytokine profiles to the aqueous humor in children with these chronic anterior uveitis, and this was found to be associated with the inflammatory arthritis. Ankylosing spondylitis, also we have some evidence regarding proteomics. These have increased levels of anti-PFD-N5 antibodies, which has a protective role against cell death in uveitis. Acute anterior uveitis. In patients with unilateral acute anterior uveitis, detectable changes were found in the ipsilateral tear fluid proteomics, and the 2 proteins were significantly found. One was increased, one was decreased in tears from the disease eye compared to the healthy eyes. So inflammation, and this further doing the ingenuity pathway analysis, these LXR and RXR pathways were identified. VKH disease, also there is evidence of decreased expression of CD18 and AKNA in peripheral CD4 T cells, suggests a role of these proteins in the pathogenesis of VKH disease. Inflammations of the RPE, in this study, human-derived RPE cell lines were used. Multiple integrated signals were exerted by the RPE, which was under inflammation, and this gives insight into the development of the therapeutic interventions for any disorder associated with inflammation of the RPE. So we have our experience in TB uveitis, and just a brief input on that. We subjected the vitreous samples of TB uveitis versus non-TB uveitis patients to proteomics. We found there were 58 differentially expressed proteins in these patients of TB uveitis, out of which 21 were upregulated and 37 downregulated. So this study provided us a baseline to explore vitreous biomarkers for ocular TB, and certain pathways we identify which were found to be upregulated, and certain pathways we found to be downregulated as compared to the non-TB uveitis group. So coming to the clinical applications, why proteomics is important? A lot of clinical applications are emerging regarding the use of proteomics in clinical practice in terms of personalized medicine. I'll not go into the details, but these are some of the examples where people have used the proteomics to recognize some of the entities that were not clinically identifiable, like a case of autoimmune retinopathy, and in a case of sarcoid uveitis, when you have to differentiate it from TB uveitis, and also differentiation of Behçet's disease from other autoimmune diseases. Work has been done in eyes with PVRL, and CD70 was found as a potential novel biomarker. So just to read the role of protein biomarkers in uveitis, this reference can be used for more further reading. Thank you very much for this talk. Thank you.
Thank you, Dr. Rima, elucidating the various protein biomarkers in uveitis. I think someday it will come that with a certain protein biomarker we would be able to diagnose a particular type of uveitis, and this is really a new things which is coming up. I wanted to bring out this today's instruction course, some of the basic understanding of the autoimmune uveitis. So in this tune, I like to call upon Dr. Shomava Bosu, who is from LBPI Hyderabad, uveitis services, and as well as the retinal vitreous services. He would be talking on retinal vasculitis, non-infectious versus infectious, how to distinguish. Shomava, please.
Thank you, sir. Audible?
Yes.
Is that audible? Yeah. So thank you very much. I think there is some mistake with the SOM. The wrong SOM is there. Somshila is not even here.
Something is not there. Either.
I could take care of that as well.
Shoma Babashi.
So while the slide is being put up, thank you, sir, for including me in this IC, and all of you for spending your post-lunch session here and reaching this hall without getting lost anywhere else.
No.
It's come.
Isolated retinal vasculitis still accounts for almost 10% of all uveitis, and besides this, retinal vasculitis is associated with majority of posterior and panuveitis, so it's very, very common. Then what makes it different from systemic vasculitis? And here the main difference is that unlike systemic vasculitis, which is based on a histopathological diagnosis, here we do not have one, but we have the advantage of direct visualization of the vasculitis process. We see how it evolves and how it resolves in response to treatment. Then the other difference from systemic vasculitis is that it's very commonly associated with infection and with systemic disease, while it is rarely associated with systemic vasculitis such as the ANCA-associated vasculitis. This is a very important concept I would like the audience to take from here, because very often when we see a retinal vasculitis, we are very tempted to investigate for systemic vasculitis. That is not the case. On the other hand, retinal vasculitis is associated with infection more commonly and with systemic disease more commonly. So in this talk, we are going to discuss how does infectious retinal vasculitis manifest, and when it is less likely to be infectious, and what are the signs of the systemic disease that can be found in association with retinal vasculitis. So this is a brief overview of how you look at a patient who comes to you with retinal vasculitis. You look at the type of vessel, whether the arteries are involved, whether it's the veins or both. The size of the vessel is always the small sized vessels in case of the retinal vessels, and the morphology of the infiltrates. Are those skip infiltrates or are those confluent infiltrates? It's very important to describe all these findings. But the part that we are going to discuss here are what are the associated ocular signs and what are the associated systemic signs that will lead you to the diagnosis of either an infectious retinal vasculitis or a systemic disease associated with a retinal vasculitis. So this is a general dictum, it's not a hard and fast rule, but to look for systemic vasculitis, for infectious retinal vasculitis, look for other signs of posterior uveitis and specifically look for any evidence of retinitis. The best example of this, I guess, would be the tubercular retinal vasculitis. Now here are the lesions that you would want to look for in cases of tubercular retinal vasculitis. This one, which I have pointed out here, is an active retinitis lesion, and the other one pointed out here is an inactive chorioretinitis lesion. By the time the scar is formed, probably the choroid is also involved. The other feature that we have recently described is the presence of this focal vascular tortuosity, which unfortunately is pretty low down in the image, not very well seen there as well. But if you see at the red-free photo, you can appreciate the tortuosity of the vessel inside this area of perivascular infiltrate. Now these are the features we have found in a TB endemic population could be suggestive of tubercular retinal vasculitis. The third one, which can also be seen in many other forms of vasculitis, is the presence of occlusive vasculitis. Now important to remember here that this lesion that we see here in association with the retinal vasculitis in TB is most likely an intraretinal lesion and not a choroidal lesion to start with at least. And this we have demonstrated also in histopathological section of the retina. So what happens when we treat these patients with So what happens when we treat these patients with anti-TB therapy? You can see that this patient who presented to us with this retinitis lesion over here and dense perivascular infiltrates and neurosensitive detachment at the macula, after 4 months of anti-TB therapy alone, this one has resolved so drastically in this particular patient. May not happen in all patients, but this is what we find, clearly suggesting the infectious nature of the retinal vasculitis in this patient. However, very important to remember that not all subvascular lesions are TB. You can see these two subvascular lesions here in this picture, and you can also make out the sclerosed vessels and the perivascular infiltrates. When we do a fluorescein angiogram, you see the extensive capillary non-perfusion areas in the periphery in both eyes. Now, when we investigate this patient for tuberculosis, we find that the MON2 test is negative and the quantiferon is negative. There is no history of TB contact. However, we find that the TPHA is positive and the patient is also HIV positive. We diagnose it as ocular syphilis and treat it with benzyl penicillin for ocular syphilis. Now, the other sign of posterior uveitis you want to look for are these presence of retinitis sitting next to a healed chorioretinal scar, and this, as you all know, is recurrent toxoplasma retinochoroiditis. Now, in these patients with recurrent toxoplasma retinochoroiditis, you will also see the perivascular infiltrates here, and if you go to the original 2005 Sun classification paper, you will see that there is kind of a argument about whether to call these as true retinal vasculitis or not. Now, these patients don't just have this form of perivascular infiltrates. As the lesions heal, you also get another form of perivascular infiltrate, which you see as this segmental whitening over here, which is called as Chiariles arteritis. Now, you don't need to treat this kind of vasculitis separately. You just treat the toxoplasma infection and the perivascular infiltrates resolve on their own. This is how it appears. Now, this might seem very simple. The difficult part is when the toxoplasma lesion is lying in the periphery, and unless you examine the fundus very clearly, you may be carried away by the perivascular infiltrates alone and miss the part of the toxoplasma, which is the primary infection that needs to be treated and not the vasculitis. The other type of perivascular infiltrate, and in this case it is involving mainly the arterioles, is the one that you see with acute retinal necrosis. You see the tongue-shaped area of necrosis in the supratemporal periphery. Now, again, you don't have to treat these separately, you just need to treat the viral infection in acute retinal necrosis. Now, there is one important caveat when we keep saying that any retinitis associated with retinal vasculitis has to be an infectious retinal vasculitis. And this is the caveat. This is a patient who presented to us with this area of retinal vasculitis in the supranasal quadrant in the right eye, and a large area of retinitis and perivenous infiltrates in the left eye as well. Now, when we asked this patient about history of mouth ulcers, we found that there were history of ulcers more than 3 times a year, and we also found a left eye mobile hypopyon. So this is the way we reach the diagnosis of Behçet's disease in this patient. So this is probably the only exception where a retinitis lesion associated with retinal vasculitis is a non-infectious form of retinal vasculitis. Now, I'll just run through these systemic diseases or the non-infectious forms of retinal vasculitis, which can be broadly categorized into 3 groups. One are the systemic diseases, and these are most commonly sarcoid or Behçet's. The eye-limited forms of retinal vasculitis, which you know is IRWAN, and the rare forms of systemic vasculitis that can be associated with retinal vasculitis such as SLE or Takayasu, in which case it is called as occlusive vasculopathy rather than occlusive vasculitis, or very, very rarely, less than 1% of the cases where you can have an ANCA-mediated vasculitis. So this is an example of sarcoid. In the previous presentation, you saw the candle wax drippings that are associated with sarcoid retinal vasculitis, but in association for sarcoid, you want to look for these granulomatous capes, peripheral anterior synechiae, and these hypopigmented spots seen in this picture, besides looking for the organ-specific involvement, which would be mainly in the mediastinal lymph nodes apart from the skin, or in the CNS or cardiac sarcoid. This is idiopathic retinal vasculitis, aneurysms and neuroretinitis, also called as IRWAN, more common in females. You would want to look for the aneurysms at the Y-shaped bifurcations of the lesions, and these would be associated with peripheral occlusion and this area of macular exudation as seen in this patient. Very, very difficult to treat, but important to recognize the pattern of IRWAN in such patients. This is occlusive vasculopathy associated with Takayasu. You can see the extensive area of capillary non-perfusion but no perivascular infiltrates, also seen in conditions such as SLE or Suzak syndrome. So let's finish with this, this picture again. Now let's evaluate the fundus photo we have with us. What is the type of vessel? We know that it's a small vessel. It's involving mainly the veins, so it's a phlebitis. And we have both skip vasculitis, which are the area of small areas of vasculitis, and we have confluent vasculitis that you can see here. Now when you look at the associated ocular signs, you see that there are these subvascular lesions that are pointed out by these arrows, and sectoral hemorrhages suggestive of an occlusive vasculitis. And then when you look at the associated systemic signs, you see that the MON2 test is positive, there is a history of TB contact, and very, very importantly, the TPHA was negative. We should not ignore that part of the finding. And based on this, we reach the diagnosis of tubercular retinal vasculitis in this patient. So thank you for your attention, and invite all of you to the Uveitis Society of India annual meeting in Hyderabad in October this year. The early bird registration is still open. Thank you very much.
Thank you, Shomubha, for a brilliant presentation on retinal vasculitis. It's indeed a challenge many of the times to diagnose an infectious versus non-infectious uveitis, particularly tubercular retinal vasculitis and idiopathic retinal vasculitis. So you elucidated not only that, but also various types of infectious uveitis and systemic diseases associated with the retinal vasculitis. We have got 15 minutes discussion at the end. Now I call upon Professor Vishali Gupta from PGI Chandigarh to talk on immunomodulators and biologics. Can they change the course of non-infectious uveitis? Dr. Vishali Gupta, please.
Thank you very much, Dr. Biswas. Thank you very much, sir, for the very kind invitation for this instruction course. The topic that has given to me by Professor Biswas is immunomodulators and biologics. Can they change the course of non-infectious uveitis? Now, before we start talking about changing the course, the basic question, why immunomodulate? So corticosteroids, as we all understand, are the first drugs which we all use in non-infectious uveitis, but when we use them on long-term basis, there are lots of side effects. So we invariably shift to immunomodulatory therapy in the cases where you need more than 10 milligrams steroid per day beyond 3 months to control the inflammation. Patient is not able to tolerate steroid, resistant to steroid, or there is a severe sight-threatening non-infectious uveitis that is expected to have poor outcome. So immunomodulatory therapy, we have two categories. One is the conventional, including methotrexate, MMF, azathioprine, which is generally the first line. And now we have got biologic response modifying drugs, which we commonly call biologics. They are generally added when the conventional drugs are not working, but now that we are getting more comfortable with them, they are becoming first-line therapy in diseases like JIA or Behçet's, which are very severe form of sight-threatening uveitis. There is this whole lot of chemical response or mechanisms of uveitis, and when you think about it, there are lots of cycles or lots of chemokines which need to be targeted, and therefore many a times you may have to combine therapies because a single one may not work till the time we have reached a stage where we can give personalized therapy. Now, can they change the course of non-infectious uveitis is the question which is the topic of my talks. Well, the pro is yes, they can, because they help in reducing the recurrences. Now, why are you so scared of recurrences? Because every time there is a recurrence, there is a residual structural damage. You may feel that, well, patient came to you, you treated with steroids, and 4 weeks later you tapered off the steroids, patient was fine, but again comes back after 1 year and you give another dose of steroids. It might work in some diseases, but every attack will lead a structural change and some change in the integrity. The problem with these is that these drugs have their side effect of their own. So it is not that every form of uveitis you will put them on these drugs because you don't want recurrences at all. So how do you go? We come back to my favorite thing is categorizing the uveitis or phenotype. Look what type of uveitis you are seeing, because all the anterior or posterior or panuveitis are not same. Within that broad classification, you have very different diseases which have very different prognosis. So you may be dealing with some of the diseases like posterior uveitis. This is APM-PP, which we don't see much in India. But well, this is the classic image of Dr. Don Gass. So this is APM-PPE, or you may find mutes. And mutes somehow we have seen almost 3 cases following COVID vaccination now. So don't panic, because many of these are self-limiting. So it's not that you are seeing and you start the patient on immunosuppression. Just wait, for some time till you are investigating. And within 1-2 weeks, you may see the condition has started responding or resolving on its own without treatment. The second category of uveitis comes monophasic, but it is recurrent. And HLA-B27 is a very classic example of it, where acute attack comes with a bang, goes away with topical steroids. You don't even need oral steroids to treat that attack majority of the time. And you keep the patient on 1 drop, 2 drop steroids for some time. He will be off all the recurrences. So you don't really have to push biologics or immunosuppressants in this patient, because these attacks do not really lead on to any long-term damage. Now we come to the third category, which is posterior or panuveitis, and these are the conditions VK8, sympathetic, Behçet's, and necrotizing scleritis. If you see, these are the conditions which are really going to be multiple episodes, recurrences, leaving a lot of morbidity and maybe mortality in patients like Behçet's. So these are the diseases that would require a long-term immunosuppression and maybe biologics to begin with. The decision to treat individual patient and the choice of therapy always keep a list of risk-benefit ratio. What is the risk of the therapy versus what is the benefit of the therapy, and most of the times you will get answer. Now let's begin with one of the most difficult cases to treat is juvenile idiopathic arthritis. Now, sophisticated time-updated modeling of GI-associated chronic uveitis has shown that any inflammation in these children doubles the risk of visual impairment and triples the risk of blindness, which means you cannot afford I do see, sitting in where I am, patients carrying the prescription because the prescribing doctor was too scared of giving steroids, either topical or oral. So very typically they start, and then even before they see the response, they already tell them to taper it off. That is not what is going to work for JIA children. They are going to get blind out of that kind of protocol. Similarly, there is Bechet's. There is a beautiful site cohort study which says that active uveitis in Bechet's increase the risk of visual impairment 2.5 folds and blindness 2.7 folds. So here the risk of giving steroids, biologics, immunosuppressants is much less compared to the benefit of preventing blindness. Systemic immunosuppressive therapy, the lessons that we have learned so far, and by and large they have come from the beautiful trials done by John Campen's group, is immunosuppression reverses visual field loss, normalizes retinal damage that you may see on OCT, and complete suppression of inflammation halved the risk of choroidal neovascularization versus active uveitis, whereas minimally active uveitis was no different from active uveitis. MUST trial is something which actually gave us the confidence to treat. It had 7 years follow-up in uveitis patients, and it showed that if you give regional therapy with fluocinolone acetonide implant, it was associated with an 81% excess risk in the odds of blindness versus systemic therapy with steroids and immunosuppression. The answer is very simple. You are treating a patient of Bechet's or VKH who's going to have lots of extraocular manifestation. You cannot really treat it with Ozurdex implants and local, because in meetings you will see somebody showing you a beautiful picture. Lady came with exudative detachment, I injected Ozurdex, detachment went away, all good. But you don't know what happened to that patient 10 years down the line. Is that patient still seeing or not seeing? So don't get carried away too much by just treating local. Local is a good adjunct, but not a supplement to systemic treatment. And each relapse prior to re-injection or re-implantation, because you can't really fine-tune the timing of re-injection and there would always be delays in the real life, this causes cumulative damage, which has been defined as sawtooth decline. So evidence of effectiveness of immunosuppression has been very well documented in birdshot, multifocal choroiditis, late stage of VKH disease, and of course JIA uveitis. Site cohort study dealt with non-alkylating agents and alkylating agents. Alkylating we are not using anymore, but non-alkylating they do help. This is beyond. Very few further minutes I will take about the biologics, which mainly we are using anti-TNF, and the systemic review by expert panel of American Uveitis Society recommended infliximab or adalimumab as the first line therapy for Bechet's and second line for JIA. But by and large, even JIA, some of us, including the rheumatologist and pediatric rheumatologist, have moved on to biologics as first line with the addition of methotrexate. So using this regimen, over 80% of the patients could achieve inactive uveitis with successful corticosteroid sparing, and that's a big thing. You don't want a child stunting body growth, no bone growth on steroids, Can steroids be tapered early with biologics? That's the question which many people have asked, and we have two trials. One of the patients with active uveitis and one with suppressed uveitis. Both showed that more than 50% reduction in the relapse rate with adalimumab in the face of rapid oral corticosteroid therapy. So if you are scared of giving steroids in JIA or something, you are giving biologics in that scenario. By the time biologics are taking over, you can reduce steroids. So this is the kind of the thing. If you have seesaw kind of inflammations coming back, majority of these children will end up in a scenario like this. Syncamore is another multi-century double-masked clinical trial which randomized active JIA to receive methotrexate or in combination with adalimumab, and they found that treatment failure occurred in 60% if you give only methotrexate and 27% if you combine adalimumab. So it's worth taking the risk of giving. And can I take 2 more minutes? I don't know why I made such a long talk. I'm surprised. Well, if your colleagues in the other part of the world are seeing and reporting some etiologies, it may be you are missing out on them. For example, these are the patients with granulomatous uveitis. And we were thinking, are they JIA? Because we love calling JIA to all the patients with children, when they come with uveitis. Well, they were not TB, they were not sarcoid, they were not positive for JIA, but they were labeled as JIA. And this is the kind of the fluorescent diffuse leak. HLA-B5 was negative, no evidence of Behçet's. And when we started looking for NOD2 gene, which is an autoinflammatory Blau syndrome, these children, we have quite a few of them who are positive for that. So some of children with these kind of autoinflammatory diseases, you can see this is post-treatment with adalimumab. This is what you want to achieve, that anterior segment looks good, posterior segment looks good, no residual effect of the disease. That is something the early intervention with these drugs can do. So my last slide, do IMT and biologics influence the course of uveitis? Yes, they do, by reducing the recurrences, by reducing the complications, and not only that, by reducing the systemic complications also, because when you are treating them systemically, you are treating the extraocular disease as well. Thank you very much, sir, once again.
Thank you very much for the wonderful, elegant talk. We are now really moving more to the immunomodulators in general everywhere. And biologics has come up, and we are switching to biologics, many of the cases like JIA and Behçet's, which you have highlighted. So thank you very much.
Thank you, sir.
If we have got time, we'll have the discussion. Now I call upon Dr. Somashila Murthy from LVPI Hyderabad, who would be talking on HLA-B27 associated uveitis and role of microbiome. I wanted to have actually the immune-mediated uveitis, the basic understanding to improve, and microbiome, proteomics, and immunomodulators has helped us to understand the disease much more.
Very good afternoon, everybody. I apologize for my being late to reach this session, and I'm sure you must have had a very interesting session so far. I'll wrap it up with an oft-repeated topic, so I thought I'll cover a few different aspects in HLA-B27 acute anterior uveitis, and then move on to ocular microbiome. So the two a little bit unrelated in certain ways kind of topic. So we all know that it's non-granulomatous inflammation, and it's an alternating uveitis in either eye. Very rare that I know, I'm not even sure if you have a patient presenting saying that exactly on the same day they had the disease in both eyes. It's usually sequential, very rarely simultaneous in that way. So the prevalence of HLA-B27 in patients depending on which study you look at, varies from 50 to 75%. And at least in my clinic, because I'm more of an anterior segment specialist, and I look at a lot of anterior uveitis, most of the patients that I see with this entity, and for me, age is not really a criteria. I've seen many older patients also present for the first time to us, but then they turn out to be HLA-B27 positive. So this is my initial test. I put their money on this test for patients with non-granulomatous anterior uveitis, even if they can have severe presentations, such as when they walk in with a very bad-looking hypopyon kind of a uveitis, or they have a very low-grade inflammation. So either of the two. So we all know that it's a male preponderance. We know that there are always recurrences, maybe one episode a year, maybe one episode in 5 years, maybe multiple episodes in the year. So the hallmark would be that every time the episode comes in, if you identify and treat it adequately, so the mean duration of resolution would be about 4 to 6 weeks per episode, and it improves very well with topical medication, we all know that. But in patients with multi-recurrent disease, and if you're not aggressive enough when they come to us, or we don't use treatment adequately, then they do end up with problems such as cataract most of the time, or cystoid macular edema. And especially some of our patients land up, and it's probably more in the Indian subcontinent or in our context, they come to us with undetected HLA-B27 systemic manifestations, that they've had the ocular disease for years. So they land up with the cataract, and then you have a patient in front of you with active inflammation, and you have to operate on these patients. So this is some of the patients who show up over the age of 50 or even 60, and literally you're the first person to diagnose that the patient has ankylosing spondylitis or some of the other associated diseases where you have an HLA-B27 spectrum in all of these 4 that I've listed. And this is one of my patients who presented to me almost when he was 59 years of age, and presented all his life he had bilateral sequential recurrent anterior segment inflammation, always used some medication prescribed to him, and then he would get better. And then when he came to me, he had very advanced ankylosing spondylitis, as well as bilateral cataracts and active inflammation. So we had to control everything and then go ahead and do surgery for him. So the less known aspects is what I thought I would just quickly roll in, is the posterior segment complications. And based on the literature that I searched, it can vary as it's usually not expected to be very frequent. Perhaps we would average it out and say less than 25% patients would have posterior segment involvement or complications or posterior segment inflammation. And this you can see as vitritis. Very often it's a spillover vitritis when you have a very dense anterior part of the inflammation. Pars plana exudates are very rare but have been described. You can have papillitis, which is just another sort of a sign that you have in quite severe inflammation, and very rarely retinal vasculitis as well. Cystoid macular edema is more related to the chronicity of the disease, the multiple episodes, and perhaps maybe not adequate or less aggressive treatment. And chororetinitis and vitreous hemorrhage are extremely rare. So intensive topical steroids is the need. And of course with mediatic cycloplegic agents for these patients. And this is one of the entity where if the patient comes to you, literally you're like a magician for the patient, because in a few days the patient gets intense relief from a very severe symptomatic disease. And even if there's a coagulum, the patient sometimes presents to us with hand motions or a counting figure vision because of the coagulum covering the pupillary area. So the coagulum just shrinks over 2, 3, or 4 days, and the patient starts reading on the chart and feels like you're some sort of magician. You're not. It's just how the disease responds very well to topical steroids. So what about the other agents? As Dr. JB mentioned, that we really try to move away from systemic steroids, as Dr. Vishali Gupta presented to us so eloquently, that systemic steroids cause so many side effects. So we often see that many ophthalmologists tend to start oral steroids for these patients because the disease looks very intense and very scary and severe. You don't need to. Or if at all you really must, for the patient to rapidly get better, I think a week is adequate, and after that topical steroids do take over. So systemic steroids are very less frequently required, and in most of the studies that less than 5% patients or a very small concentration of patients would need systemic steroids for long term. Instead, if the patient has multiple recurrences and needs long-term therapy, it has to be immunomodulators. This can be either in association with the treating physician, the rheumatologist, or if it's only ocular, then if you're comfortable, you can undertake immunomodulator therapy for these patients. Some of us, we do use systemic NSAIDs. They have not a very intense role in the management, and of course periocular steroids for those patients with cystoid macular edema. So the prognosis, according to me, is extremely good if treated well. The common complications, you can have cataract, which is most frequent. Secondary glaucoma would be either if the patient is a steroid responder, which can happen, or if it's missed and the patient develops sort of a pupillary block. So these are the two causes of secondary glaucoma, and it's really a poorly treated disease that causes this secondary glaucoma complication. And some patients very rarely can have chronic anterior uveitis, and those patients I would put them on immunomodulators right away. So that was just in a nutshell about HLA-B27 disease. I'm moving on to the role of the ocular gut microbiome in uveitis in general, and almost similar results that we have seen in some of our patients with HLA-B27. So of course here the entire work is credited to Professor Shivaji, who was our director of research, and it's his project that he has extensive experience in studying the gut microbiome in various diseases, and his entire team, of which we were part of. So the microbiome, because it may be new for some of you here, it's the community of microorganisms all put together, which are termed the microbiome. And the gut at birth is sterile, but then very soon it gets populated by the normal, what you call commensals of the gut, and this is what keeps us going, in the sense that it varies with age, ethnicity, diet, there's genetic variation, and then there's pathological conditions based on so in young people we see something called more of actinobacteria, and then in elderly individuals the more of proteobacteria. So this reflects upon, as we grow older, the disease-associated pathogens increase. So is it important? Yes, it is, because it carefully balances what is good for us and what is bad in terms of the opportunistic organisms. And all of our diet and everything of late has been attributed to an imbalance in the gut microbiome, leading to manifestations in various diseases. So it's this gut microbiome displacement, or a bad microbiome, is called dysbiosis, which is implicated in several of these autoimmune diseases, and of course uveitis is one of them. So it can be associated with uveitis as well. So taking that as a hypothesis, what we did was to look at the gut microbiome in patients with uveitis. And it was a very systematic kind of work that was undertaken by the team, which I'll not go into, and just sharing some of the clinical data in which we had patients, we had a wide group of population because of the nature of the work involved. We had to take with patients from different diseases, not just HLB27, that was a subgroup of this. And the contraindications, we had to be very certain that we're not looking at patients with other disease, so to make sure that we didn't have those in them. So this is going to be a confusing slide, but in a nutshell, what we saw, and I'm just putting it very simplistically without taking up too much time, is that in our healthy controls, which we obviously needed healthy controls, we saw that the beneficial or the anti-inflammatory or the probiotic antimicrobe agents, the anti-inflammatory gut flora, their population, which I've put in blue, was much higher. Whereas in the patients with uveitis, and we could show it was very significant that the pro-inflammatory pathogens, their population was much higher, what is listed down there in the white box. So in other words, what it does mean is that it's not just various other diseases such as I mentioned earlier, for example, even cancer and so on, but it's also in ocular diseases, uveitis, and in Behçet's disease, specifically in anti-uveitis. So this has been shown either in the murine model or even in patients, as well as age-related macular degeneration and dry eye and so on. So bacterial and fungal keratitis was published by our same group. So it has been shown that there's change in the gut microbiome due to dysbiosis in various ocular diseases. So what we concluded in our paper was that the uveitis patients, they had an altered gut microbiome, and they were the anti-inflammatory gut microbiome were less, whereas the pro-inflammatory and pathogenic kind of a gut microbiome was much higher in patients with uveitis. So where does that lead us? Perhaps obviously towards our therapy and to get rid of, it's very simplistic to say that to make the patient better, we can just alter the gut microbiome and improve it. But perhaps it's a huge interrelated cycle. That's just one of the factors. Perhaps that's an easier thing to improve. So perhaps we can improve that as well. So thank you once again for accommodating me, Dr. JB, and thank you everyone for listening.
Thank you, Shamshila. Nice presentation. There's a lot of time patient asks that, should I change my diet? Is the diet I should do any change in diet, or is the diet has got any role? Earlier we used to tell that no diet, you don't need to change the diet. And now if the patient asks the questions, in the back of my mind that these papers and this works comes in my mind, and I tell that probably that we do not know, but it might have some kind of a role. So gut microbiome. So earlier our Ayurvedic people were using the diet changes very much for treating several types of the diseases. So I don't know whether we need to sort out that one, and whether there is any kind of antibiotic will come in the picture of treating the uveitis cases simultaneously with anti-inflammatory agents. So we have got 2-3 minutes time. Thank you very much. We have got 2 to 3 minutes time. Now 2:55 we have to conclude this course. Anybody has got some questions? Rima is supposed to start the next course. So, any questions from the audience side? Yeah, 5 minutes, okay, till 3 o'clock. I just want to know that one of the things is that from Vishali, that what is your practice on doing bone scan in chronic steroid usage of the patients? How often you do it?
Not much. It should be done. But we have our rheumatologist with us in the clinic, so whenever you want, we get.
And recurrent non-granulomatous anterior uveitis, how often you put on the methotrexate? Recurrent non-granulomatous anterior uveitis. Patient says that last 3 years he has got 20 attacks. And
Sorry, sir. So the question is recurrent non-anterior uveitis, multiple attacks. That's the question.
Yeah, non-granulomatous anterior uveitis.
So non-granulomatous anterior uveitis, like it would be HLA or HLA-B related this. But if the attacks are too frequent, normally what I do is that I start them on topical steroids, but we do not taper them off very quickly. Like if you're starting 1 hourly a day, you give it for about a week, 10 days, till the time the inflammation is quiet. Make it 6 times a day, then make it, and it's very slowly. If the patient is having recurrence, suppose when it's going down to 1 times a day, I will just keep him on 2 times a day for quite a long time, which could be 6 months, 8 months, 10 months. If the patient is having recurrence at 1 times a day, then I would be keeping him at 2 times a day. So, but if patient is having so much recurrences, 20 recurrences in a year, I think the first thing is the compliance. Is he compliant with the treatment that you are giving, or is he missing out? Because that's a very common cause sometimes. They just do not put drops very seriously. If we are sure the patient is compliant and having this much recurrences, I always get MRI, sacroiliac joints and others done, and many of these patients on celazopirin concomitant, and many a times I do not really know whether celazopirin helps in reducing the recurrences or not. There is some literature on it, but many of them are there. But still, if there is so recurrent, that exceptional case, yes, I would go for immunosuppression.
So I often try to give that one, like the patient says, last 10 years I have got every month a recurrence, or last 4 years. I put the patients on methotrexate, I do find that there is a time of the number of recurrences has get reduced. But how long to keep the patients on methotrexate is a different question.
So by and large, most of the studies on endpoint have shown 2 years after achieving quiescence. Sure.
My question is about the pediatric uveitis that you mentioned. It's very interesting that so many of our patients, and I think our experience also says that they come with granulomatous keratic presbyrates, and JIA by definition should not be having. So I understand some of these would be classified as blau, but what about the ones that do not have the systemic signs or the NOD2 mutation? How do you classify them? That's the first question. The other question is, how well does your adalimumab work in blau patients? Because theoretically speaking, it's not supposed to work. So do you look at other options? How well does methotrexate work in those patients?
There are two parts of it. One is quite a few of them actually had TNU also. Now that we have started looking for beta-2 microglobulin, which we were not doing early. And there is a paper by Carl Herbert who says that JIA causes granulomatous uveitis. So that is another angle to it. But whenever we see granulomatous uveitis, we always try to rule out things other than JIA. If still nothing is coming positive, you still ascribe it to JIA till you find a better, name for it. The second question is adalimumab by and large in blau should not work. But the thing is, we always combine it with methotrexate for the fear of anti-drug antibodies. So honestly, I do not know whether it is the methotrexate which is working or adalimumab which is working. Yeah, come.
What we have seen is generally in this granulomatous section of uveitis in children, they all require a minimum amount of steroid for a very long time, and it all depends on if they are detected very early. If they are detected early, they work very well with methotrexate and mycophenolate. But the ones where they've already developed the BSK and all that, they are the ones who are very resistant to therapy. We've started using tofacitinib in this.
Yeah.
But again, it's, initially they do well, and after a point of time, again, it becomes status quo, and you need that minimal amount of steroids still.
Yeah. For all of you, tofacitinib is one of the JAK inhibitors, causes reactivation of herpes. So some of these drugs are only for, when you are really pushed to the wall.
So I have got a patient, ophthalmologist, scleritis. I treated with the JAK inhibitor, and patient's scleritis resolves. And then when I put the patient on slit lamp, I found he has got herpetic keratitis.
Next session का program है आपके पास? I think Rima is held somewhere. Should we start the next?